Welcome to Orthodontic Smiles, the podcast designed for all dentists and their staffs who practice orthodontics. This podcast is brought to you by the American Orthodontics Society. Orthodontic Smiles tonight is really happy to be able to have a very special person as our guest and available for interview, Dr. Ralph A. Nicassio. He's a graduate of UCLA in '85. He has been in practice with an emphasis of prosthodontics and orthodontics in his practice, and he has been a lead instructor in the progressive orthodontic teaching for over 20 years, and then he started his own company, Advanced Dental Thinking Seminars, for the past 12 years. This man has taught over 800 days in 19 countries and produced 40,000 complete treatment plans for his patients. And I'm so happy that he is a contributor to the AOS Journal, and he has given us some of the best articles and the most complete articles that I have ever seen. So, Ralph, I want to thank you for being on Orthodontic Smiles podcast. You've been somebody I've been wanting to get on the show for a long time. It's hard to get some of these people to get on the shows. You're busy, but I thank you so much for breaking out some time for us to talk.
It is my pleasure and honor to be with you. Well,
good. Let's talk about this. I mean, you've been an advocate for orthodontic education with GPs, and you've been doing this for so many years. Tell me why you think it's important a GP should be able to do orthodontics.
Well, it is my opinion that you cannot truly be a great general dentist unless you know something about orthodontics. And I know that that would offend many of the fine colleagues in our profession. But I remember thinking I was doing wonderful prosthodontic work. And then after learning a little bit about orthodontics, I started to question whether my work was nearly as good as it could be. So I think we see the world through what we know, and when we look in a mouth through the lens of some orthodontic knowledge, I think we offer patients things that other dentists simply can't even imagine.
Well, so many GPs just think about the fact that they can introduce orthodontics into their practice by just uprighting a molar to be able to put a bridge in, or just getting a tooth in a better position to be able to do some cosmetic dentistry. That's kind of the way it started back a long time ago. It's sure progressed since then.
It sure has. We're not just molar uprighting. We're correcting periodontal problems, and we're enhancing aesthetic outcomes, and fixing TMJs. And in fact, I think if you don't have orthodontics as one of your main armamentariums, I don't know how you can really correct many TMJs. And I know that would really offend a lot of the occlusion sycophants out there that think that it's all about centric relation.
Yeah. Well, I have found, at least in my communities that I have practiced in over the years, that it's usually the GP that's out there doing the TMJ work rather than the orthodontist. They actually are the ones that are referring a lot of the TMJ difficulties to those GPs who have studied TMJ correction and gone on from there.
I like to remind my students that they should recall how much they really thought they knew about dentistry when they first graduated from dental school. And for many of us, we probably knew enough not to hurt anyone. And I would suggest anyone that goes on into a master's program, whether it be prosthodontics or oral surgery, endodontics, I know you're a pedodontist, you learn a great deal about your specialty, but you didn't know that much more about how a mouth works than most GPs. And so I find that many specialists are out of their league when it comes to cross-disciplinary aspects like TMJ.
Well, you've been one of the I like to call you, now that I know you well, I like to call you the renegade of the AOS. You and I mean that in a very good way, because you are not you're not the kind of person that backs off of difficult cases. You've treated them differently than most of us might, and you're not afraid to be able to take a tooth out when you need to, and the cases come out beautiful, Ralph. I've been so impressed by looking at some of your cases. They are really, really good, and I'm now really excited about the fact that you are so into this early treatment stuff.
Well, I think that in order to give our patient the best chances of being successful in phase 2, they often must and could greatly benefit from some early treatment. And I've tried to write about that in specific detail. In fact, I wrote a 4-part article for the AOS Journal. I was trying to make a contribution and demystify this and help clarify the thinking of many of our members that want to do optimal early treatment.
Well, you did a great job. You asked me to read that thoroughly, and I did, and I was very, very impressed by that. That was a very good treatment philosophy. I think what early treatment has to do with those of us who deal with it every day is that you have to develop a philosophy of where you want to go from the very beginning. In other words, what do I want to end up with? And so how do I start a case to be able to end up in that position? And I'm always looking for, I always tell my students when I teach them, I said, how would you, if you were doing, if you were an orthodontist and you were doing a full comprehensive case and somebody walked in the door, what would be your ideal situation? What would be your easiest case? You'd want a class 1 with no deep bite, no overjet. You'd want nice straight teeth. You wouldn't want any crowding. You'd want a nice round arch. You'd want a nice pretty smile, and you'd want all the permanent teeth in.
You'd be just hoping that one of the tooth came in crooked enough that you'd get to do phase 2.
Exactly. Exactly. And so that is what I strive for. When I am doing early treatment orthodontics, I am looking for that case to come in, and I finish up my early treatment with all the exact same things that I just talked to you about. And that's just my philosophy. I don't know if yours is different.
No, yours just sounds fantastic. And I know that you incorporate a lot of growth and development in your philosophy as well. So I want to give my students the ability to look at a kid and visualize what is this patient destined to look like if we do nothing. And if you don't like the answer to that question, you need to get started. So there are many class 2 cases where we could really help them by simply correcting the deep bite to permit more mandibular growth. There are many class 3 cases where we need to get rid of open bite and literally create some deep bite to put some restraint on how much lower advancement the lower incisors will experience when they hit their pubertal growth spurt. So all of these are variables, and there are patients that simply have an upper jaw that's too big for the lower, and there are patients that have lower jaws that are too big for the upper, and there are ways of orthopedically shrinking a jaw when appropriate by extracting teeth just at the right time. So all of these are tools that I'm trying to add to our students so that they are more versed and have more tools and have more control and more joy from practicing early treatment.
Well, I like the fact that you're really looking at the growth and development. I mean, you're looking at, hand wrist films. You're looking at every aspect of growth and development and trying to start those cases at exactly the right time. That's important.
Yes, there are times when some of these young kids, they look pretty fantastic, but some of these 8-year-olds have a pretty strong chin for an 8-year-old. And just to know that they've got a WITS analysis that's a red flag for potential profound mandibular growth could be a good indication to do some space maintenance or perhaps some maxillary advancement to give the upper jaw a head start before the mandible grows, or any number of things to just give that patient the optimum opportunity to have the best possible results.
Well, I'm impressed by the fact that you sent me a great article about the carrier motion appliance. How do you feel about that? We've been talking about this in several of our podcasts, and we've gotten some differing opinions. But and I know how I feel about it. I'd like to know how you feel.
Well, Ed, there are 5 ways to correct class 2. Of course, we can distalize, and we teach many of our new members how to do this with an MDA appliance, formerly known as a Wilson distalizing arch. The second method would be dentoalveolar advancement with class 2 elastics, and certainly anyone doing phase 2 orthodontics uses some class 2 elastics. The third method to fix class 2 would require orthognathic surgery. And there are certainly cases that orthognathic surgery should at least be offered to the patient. And it saddens me that our members are not introduced to this, or at least to know when it might be appropriate. And the fourth way to fix class 2, and this is really, virulent words to some of our members, is sometimes you need to extract teeth. Now, orthodontists statistically extract 20% of their cases by taking out bicuspids. 20% is the statistical average. And anyone that's listened to me knows I'm not such a great fan of orthodontists per se, not at all, but I think they know something about orthodontics. And I think our members need to acknowledge that there are many cases treated with bicuspids extracted, and they look delightful. And there are some cases that are treated non-extraction, and they look hideous, they look unstable, they're not aesthetic, and in some cases they're not even periodontally healthy. But that's been a trend in orthodontics. And just to complete this and get back to your question, the fifth method to fix class 2 is mandibular repositioning. And a carrier motion appliance is another appliance that basically postures a mandible forward and then tries to super up the teeth, and you kind of hope that it will hold. And this is no different, say, a Herbst or a Mara appliance or a Bionator. These kind of appliances have been around a very long time. Rickinator, we can go, list the appliances that are designed to posture a mandible forward, and then you hope that the occlusion holds. Now, one of the things I would like to see the AOS teach in terms of our board certification is the same standard that orthodontists meet, and that is to do Ceph overlays of all their cases. In other words, they take a starting Ceph and they take a final Ceph, and there's certain structures that are superimposed. And this is how we can document with evidence-based certainty how a case worked. So
you're learning so much by doing that. I always encourage my students to do that. I said, when you're done with your case, always take another Ceph and then superimpose it. Now we have Dolphin and other products out there that do this. It's so easy to do. But boy, you really learn a lot about what you did. It's not what you do, it's what you did.
And it's shocking to many of our members, because we have members that think they're distalizing when in fact the class 2 corrected with dentoalveolar advancement. Now, when you look at a carrier motion case, they're basically fixing class 2 in 2 to 3 months. And anything moves because you apply a force to it. And the force that's being used in a carrier motion appliance is called a class 2 elastic. It just happens to be done at the beginning of the case. And one of the things I've done, I've had the responsibility of diagnosing a lot of cases for doctors, and I feel an immense responsibility to give them a treatment plan that I can guarantee will work. And even though we all love to study the cases that worked out beautifully, I like to study the cases that failed. And many of our students that take AOS courses, this is where they feel, they feel a little frustrated, because they've been taught to fix class 2 in a certain way, and yet when it doesn't work, they don't have a backup plan. And so even though everyone says they focus on diagnosis, I seriously question how well they have learned diagnosis when in fact they try to treat every class 2 case in the same manner, whether it be MDA, whether it be just class 2 elastics, whether it be a carrier motion.
The biggest problem that I see is that they have difficulty deciding whether it's a class 2 or a class 2 skeletal?
Well, that's part of diagnosis, and posturing a mandible forward fixes a class 2 really quickly. I've taken cases that were quote unquote successfully treated with these kind of appliances, and all you have to do is deprogram them, Ed. You put them in a Lucia dig, or just have them bite down on a tongue depressor on their incisors for 4 or 5 minutes so their muscles relax, and you discover the correction was nothing more than a Sunday bite. This is not quality orthodontics.
Yeah, we both have gotten into those Sunday bite cases. They frustrate you to death.
And it frustrates our students when they try these things and they don't work, and then they say, now what do I do? And even worse, if they were to do overlays, they often discover that what they have been doing during that period of time that they've been creating a Sunday bite is seriously proclining lower incisors, in some cases retroclining upper incisors. And they've in fact made the case much more difficult to correct because they didn't diagnose it correctly.
We're talking about some pretty important stuff. Mm-hmm. And I've interviewed some of the great educators all over the world. And I'm just curious, I mean, you've been teaching for years. Let's just not talk about GPs. Let's just talk about orthodontics, because there's orthodontists out there that listen to us, and there's GPs that listen to us. How would you structure a different type of educational system that would handle these kinds of problems, that would be able to teach students the differences that you're talking about?
Well, I think we owe it to them to show them cases that should be treated with extractions. You've had some speakers that were on. I think it was Dr. Herber Simmons talked about camouflage treatment, taking out upper fours. Certainly that could be appropriate. But in my opinion, there are cases that you might take out upper and lower fours. There are cases that are best treated with upper fours and lower fives. There are cases that are best treated with upper fives and lower fives. I can go on and on and on. I happen to fix quite a few serious class 2 cases by taking out upper sixes. And I will tell you, it is so simple. There's no compliance required. The cases end up looking totally non-extraction. Similarly, in severe class 3 cases, I'm a very big advocate in situations of taking out lower sixes because it creates the most space for AP correction. Cases end up looking non-extraction. Seldom do they require any compliance. And they treat out better.
Do you use a lot of TADs?
As far as I'm concerned, I invented them. The first TAD I was doing in 1992, it was a case where I had a patient, I'm sure you've had this experience, I had a patient missing a single lower incisor. And anyone who's done orthodontics for a while knows that this can be a surprisingly challenging situation to correct. And I had a case or two missing a lower incisor that I treated only with class 2 elastics, trying to get some deep bite corrected. And they came out okay, but truthfully, the vertical component of force and the gingival display that resulted was very disappointing. It's the kind of case where everybody's saying, great case, patting you on the back, but I was ashamed of the case. And so there was a case that a boy came in with 3 lower incisors, missing a lower incisor, 100% deep bite, and I put some TADs above the upper cuspids, 4 to 5 millimeters above the upper cuspids. And my hope at that time, Ed, was not to fix the gingival display. My only hope was to try to correct the deep bite without using class 2 elastics. And not much to my serendipitous shock, not only did we fix the deep bite, but we fixed the kid's gingival display. And this led me on a very long adventure of using TADs everywhere you can think of in a patient's mouth. I find that they do not work in many places. And I also I think listeners should know that even though TADs are very fashionable, if you talk to any sales rep, they'll tell you the resale of TADs is essentially zero. In other words, everybody buys them for the first time, but they never reorder. And there's a reason for this, is because the way they're being placed in between the roots of teeth into alveolar bone rather than basal bone has an unacceptably high failure rate. And in California, for example, the dental insurance company will no longer insure orthodontists that place TADs. And this isn't because things were going well, Ed. This is because there have been a lot of problems with the way most people have been trying to apply these tools.
Wow, I wasn't aware of that. That's an interesting situation. Okay, so Henry Schein is out there promoting sagittal first, and And that's been a big dilemma, because I've had some of their own speakers come on the show and say they're not quite up to sagittal first to start with. They'd rather do transverse first and then do sagittal first. So how do you feel about that?
Well, you know, it's kind of easy to tell if you just have the cast in your hands. There are many patients that if you just posture the cast into class 1, you will discover they actually have a hidden amount of posterior crossbite. And these are patients that could greatly benefit from some expansion first to facilitate the mandible coming forward. But can we acknowledge that we've all had cases where we did expansion of the upper arch and the mandible did not come forward? We need to acknowledge these cases just as well as the cases where God was smiling down on us and the mandible did come forward.
Well, Ralph, that's been something that the orthodontists have been promoting for years through McNamara. McNamara said, okay, you have to transverse first, get that upper arch expanded, then that mandible will come forward on its own. And they have been, and by far, if you look at all the cases that I see from orthodontists, you're always going to have that RPE in and nothing on the lower. And what they're expecting to happen is to do the RPE on the upper, get the transverse corrected, and then wait for years for that lower to come forward.
And I can say I love it when it works. But what do you do when it doesn't work? Right? And then we owe our doctors, we owe our students, when we give them education, plan B or even plan C. And this is what's missing, Ed. So it's lovely when it works. I am so happy when it works, and I've experienced the joy of that many times. But I've also seen the cases where it doesn't work, and that's where I like to study cephs before and after. Not necessarily even before and after the case, but maybe sequentially throughout the treatment.
Are you a proponent of sagittal first?
No, I'm not. Actually, I'm not. I'm a proponent for sagittal first when sagittal first is necessary. And those cases are quite clear. For example, if a patient has a functional shift to one side, they clearly need their mandible brought forward on that side, but not necessarily the other side. And the Carrier guys tend to do it on both sides. And I see a big problem with a lot of facial asymmetry with this technique, and occlusal plane problems and vertical dimension problems. So, and the other issue is, what if a patient needs their mandible brought forward, but that makes them even more class 3? Oops. Yeah. Now what do we do? And there's many patients that do. There's many class 3 patients that cannot tolerate class 3 elastics for their TMJ. In fact, they need their mandible brought forward. And so this only gives us 2 other options, the 3 options to fix the real amount of class 3 these patients have.
I actually have a case right now that's just a little bit of the opposite of that. I started with a Carrier 3, and now I'm at the end of the case, and I'm starting to have to use class 2 elastics.
That's not unusual for many class 3 cases to really need some class 2, but it's also true that many class 3 patients have even more class 3 in them than we might initially anticipate. And this is often evidenced when they have a little bit of posterior open bite.
Yeah.
Posterior open bite is because the condyles are posteriorly displaced. It would be uncomfortable for them to clench on their retrodiscal tissue, so they essentially are using their tongue as a splint. And the reality is those class 3 patients do need their mandibles brought forward. But there are class 2 patients that do not need their mandibles brought forward. And this is where this idea that every time we see a class 2 case, we're going to try to treat it the same way, case after case after case, is a mistake. And it's a serious mistake. And so many of our doctors, it's MDA. Well, they realize the MDA doesn't work on a lot of cases. Yeah. So then it's like, well, let's try a Carrier motion. Oops, that didn't work on a few cases. Now what do I do? And so we owe it to them to give them more detailed and a deeper background so they don't feel frustrated. And this is the number one reason why so many doctors that take orthodontic training eventually quit doing ortho, because they feel they don't know how to escape the cases. They feel like I'm not good enough. You know, they go to someone's seminar where somebody only shows their very best cases, right, and they leave there thinking, well, if I can't reproduce that, it must be me. Maybe I just shouldn't do ortho. And this is a shame that so many of our doctors are that insecure about doing orthodontics.
Well, you know, I just to kind of give you a little bit of historical perspective, I once asked Bob Garrity I said, Bob, why are you just teaching the MDA? You teach no other form of distalization other than that. And he says, well, you have to understand, I am teaching. I'm teaching people that don't know anything. And this is the safest mechanism to be able to distalize molars. And then I asked Dave Jackson, who taught our beginning program and after Bob retired, and he said the exact same thing. He said that the reason that he suggests the MDA is that you can't get in a whole lot of trouble with an MDA. In the worst case scenario, you just take it out and it's all going to relapse back to where you were before. So
I would call that being in trouble, though.
Yeah, no, it is. But when you recognize that something went wrong, you thank God that there is such a thing as relapse. So, yeah. And we've all put our patients in those positions in the past. And
it's not a practice builder.
It is. Exactly, it is. And that is not an orthodontist or a GP out there that hasn't done orthodontics, that hasn't been in that position and looked at it and said, wow, I think I should have done something a little different than this. But things are changing, Ralph. But before we get into this big change in orthodontics, can we just stop for just a minute from a word from one of our sponsors?
Sure.
Hi, my name's Dr. Brad Williams, and I've practiced orthodontics for over 35 years, and over those years, I've had some fantastic teachers like Dr. Bill Wyatt, Dr. Bob Garrity, Dr. Dave Jackson, and many, many more. And I'm honored now to be teaching orthodontics to a whole new generation of general and pediatric dentists. I want to personally invite you to enroll in one of my basic or intermediate hands-on courses through the American Orthodontic Society. We are committed to provide your entire staff the support and training you need to launch orthodontics in your pediatric or general dental practice. And to make the hands-on experience in my classes the best possible, I've partnered with an outstanding and very ethical company called OrthoArch to provide all the orthodontic supplies my students need. When my students start treating patients in their offices, they too will benefit, as I have, in partnering with OrthoArch for all their orthodontic supply needs. You can contact OrthoArch at www.orthoarch.com. See you in class.
Thank you, Dr. Nicassio, for giving us a few moments. I'm looking at the future. I'm looking at the future of orthodontics, and things are different than they were even 4 or 5 years ago. There are so many practitioners, and I'm not just talking about GPs. I'm talking about orthodontists out there using Invisalign products, and they seem to be doing a pretty good job with it. As we interviewed Gordon Christensen, he was one who said that he has been watching this over the years, and originally he didn't think that Invisalign products were very good, but he did actually say that over the years they've improved and gotten much, much better, and so he feels very comfortable that GPs should invest in education in Invisalign. So what's your thoughts?
Well, I want to say I'm actually grateful for Invisalign and Line Technologies, ClearCorrect, and even 6-Month Smile and short-term ortho, because for many doctors, this is the vehicle that they originally get introduced into orthodontics and discover it's fun and exciting and a wonderful service for patients. And the fire is lit that they want to learn about orthodontics. But so many of them realize that they feel limited in what they can do, or they want to achieve better results than just simply handing a patient the next aligner. So I've seen some good Invisalign cases, but I love to point out the JC article just a few years ago that said that of orthodontic specialists doing Invisalign, 70% of them were eventually putting brackets on the patients to get what they consider to be acceptable results. So there have been innovations in Invisalign, and they're trying to correct class 2, and they're trying to do more things with it, and there's some wonderful results with it. but you're talking about a technique that requires the maximum amount of patient compliance, where the doctor has the least amount of control of what happens. And it's probably the most expensive way to get a result.
But that's what doctors like. They don't want to have the control. They want someone else to take that responsibility, and that is the computer.
That market will always exist, and I'm not really concerned about that market of doctors that want that kind of treatment or those patients that want that kind of treatment. I'm more concerned about training doctors that want to do a higher level of orthodontics, to do orthodontics that can never be done by Invisalign for correcting severe overbites or correcting severe gingival display cases or any number of what I consider very difficult orthodontic cases. And I take great pride in my seminars for really showing doctors how to treat difficult cases. I've attended so many seminars over the years where I never saw a difficult case. I saw a lot of crowding, or I'd see a positioning type of appliance, but what I consider to be a truly difficult case, or maybe where there was some skeletal class 2 or skeletal class 3 that needed to be overcome. And in my mind, there will always be doctors that want to reach for this higher level of control and treatment outcome. And that's my market when I teach.
Well, I'm telling you, I'm going to grab you by the hand and I'm going to take you over to Lenny Carapeza, and I'm going to sit you down with him for a good hour and let the two of you go at it, because that
friends.
Guy is probably the most knowledgeable person about growth and development and treatment as you. And the two of you put together in the same room would really come out with a great benefit to all of us, I think. He's a brilliant man, and has been in bracketing since the A Company and Andrews, and he's the godfather of there's no question, he's the godfather of early treatment orthodontics. So I want to get you guys together and talk a little bit, and that may be one of our great interviews in the future, is the two of you together talking about how we do treatment.
I would love that. And we all owe a debt of gratitude to doctors like Carapeza, to Dr. Brem, to Dr. Don McGann, to Dr. Bill Wyatt. You know the names. These are people that have been forerunners in our profession, that have made it acceptable for general dentists to do orthodontics, and they've fought the battles, and they've done the quality work that's given us the credibility. And I want to keep up this tradition of, as a GP doing ortho, we need to do it to the same level of care as a specialist. And
absolutely. And I know you teach that in your courses, and I do too. I said, don't bring me a model that looks like a cow patty. Let me see what a real model looks like. Let me see the quality. I can tell by the quality of your model what kind of quality orthodontics you do, and the type of records that you present are the kind of quality orthodontics that you do. And I know you teach the same thing.
I do. I know one of the things that I'm very proud of the AOS is that we do have board certification for our members. And I know that you're aware that the American Orthodontic Association is getting rid of the requirement for the dentist to become board certified by presenting cases. I think it is a very sad state. But, if you really study this, I have been going in at the AO conventions. I have been attending to look at the board certifications for years and years and years, and with great interest. And there's many things that can be gleaned from this. First of all, very few American orthodontists have been seeking out board certification for the last probably 20 years. Very, very few of them. Most of the names that I see in there are doctors from Korea or other foreign nationals. Secondly, another fascinating observation I have is how much the cases look almost identical in terms of arch form and finished product. And I attribute this to the fact that many of these patients started out with a certain ovoid arch form that seemed to match the appliances and the wires that are commonly used in orthodontics. If patients presented with an initial square or tapered arch form, they could never get a good enough result with the current appliances being used to produce a case worthy of board certification. This is why I am teaching doctors to use more customized appliance, customized arch wires, customized bracket prescriptions, customized treatment plan, anchorage, mechanics. And this is the kind of thing that's enabling doctors to treat much more difficult cases easier and better than before. I must tell you, Ed, the number one thing that I get asked to speak about, and I imagine almost anyone, yourself included, who teaches in orthodontics, is they want me to talk about finishing. And I think they think that when I show up to talk that they're going to learn some tricks in 2 days so they can escape from their cases that they've started and they can't get out of. And the reality is when I look at their cases, they can't finish because they never started the case correctly.
Exactly. Your cases should finish naturally. If you did a good job on the front end.
And uneventfully and in a timely manner.
Exactly. Exactly. You're absolutely right. Ralph, you're absolutely right. And that just comes with years and years of having done orthodontics. I mean, we learn that, but we're in a different phase of our lives that we're out there trying to teach these young people orthodontics, and we have to manipulate them and the way we do our treatment to be able to help them understand it better. It's kind of hard for them to understand that after 30 or 40 years of doing orthodontics, all of a sudden they're going to get it,
Many of our doctors are trying to do a one-size-fits-all case sort of scenario. And for example, if a doctor's using a Roth prescription and they decide they want to extract teeth for any one reason, there's almost no chance they can get a good result. There's no reason that extraction diagnosis has been given such a bad name, because you have people that don't know what they're doing, using the wrong appliance, getting bad results, and then criticizing the entire technique. We need to elevate what we do in orthodontics. If you really think about it, Ed, the only new things we have in orthodontics in the last 50 or 60 years is self-ligating brackets and colored elastics. Mandibular repositioning is not new. It's been around a very long time. Class 2 elastics are not new. They've been around a very long time. But I think it's time to update our teaching, give our doctors state-of-the-art training from day one. I've proven they can handle it. I've always said the test for any teacher is not what they say or what they show. The test for any teacher are how reproducible the results are in their students' hands right out of the gate.
Well, Ralph, you have proven you're a great teacher, and your courses are available on the American Orthodontics site. So I encourage anyone that wants to take one of your courses to go on to orthodontics.com, and look at all of the courses that are available out there, not just yours, but all the others. And we've got proven methods of being able to have young general dentists learn orthodontics and do it in a magnificent way. I am so proud of our diplomates of the American Orthodontic Society. I put their cases up against anyone in the world because their cases are just incredible, and they learned so much from people like you and all of our instructors at the American Orthodontic Society. So, Ralph, I want to thank you so much for being on Orthodontic Smiles podcast. This has been one of our best technical, and I enjoy doing the technical ones because you challenge me to be able to be up on my orthodontics when you're talking to me about cases and certain specific things. And so I enjoy these technical ones, and I know that our listeners enjoy it as well. I get emails all the time from orthodontists as well as GPs who really enjoy the technical aspects of what we talk about in our interviews. So I want to thank you so much, Ralph, for being on Orthodontic Smiles podcast. I look forward to maybe getting you on again, maybe with one of our other instructors to have a heart-to-heart interview. Thanks for being on our show, Ralph.
Ed, the quality of your courses precedes you as well, and I thank you for your contribution to our organization.
Well, thanks.
This is your host, Dr. Ed Gonzalez. I want to thank you for listening to Orthodontic Smiles today. If you enjoyed our broadcast, please click the subscribe button. We'll be in touch with you in the future about our further broadcasts. Thanks for listening.